The recent rise in COVID-19 cases across Southeast Asia has sparked concern amongst health officials and the public alike. The JN.1 variant, a descendant of the Omicron BA.2.86 lineage, is at the heart of this resurgence. The World Health Organization reports that this variant boasts a staggering 30 mutations, amongst which are LF.7 and NB.1.8, the primarily subvariant fueling the current uptick in infections. With the number of cases surpassing the 1,000 mark, particularly in states like Kerala, Maharashtra, and Delhi, businesses must urgently reassess their preparedness for the unexpected resurgence of the virus. COVID-19 progression can be characterized by three distinct stages, with the final phase being particularly alarming. It is marked by an excessive release of cytokines, leading to a situation known as cytokine storm, a catastrophic immune response that can have devastating effects on the body. Moreover, studies have identified the presence of anti-IgE antibodies against SARS-CoV-2 during this critical phase, indicating a possible link to the severity of the illness. Knowing this, how can we bolster our defenses against such a formidable foe? The WHO Pandemic Agreement outlines essential principles and strategies aimed at enhancing global collaboration in various critical areas. This framework aims to fortify the world's health infrastructure for better pandemic prevention, preparedness, and response. A key focus is on ensuring equitable and prompt access to vaccines, therapeutic, and diagnostic for all nations. Our promising approach is the use of oral antivirals, which can significantly reduce the risk of adverse outcomes in high-risk patients infected with COVID-19 variant. This treatment avenue could be a game changer in managing the health impacts of this virus. It is imperative for individuals and organizations alike to stay informed, remain vigilant, and take provocative steps to protect our communities. Let's not wait for the amplification. The coronavirus have evolved, creating new strains that appear to spread and infect more easily. Respiratory syndrome, coronavirus, SARS-CoV, and MERS-CoV. The SARS-CoV virus responsible for the current pandemic has undergone continuous genetic changes, resulting in various variants significantly distinct from each other. Viral genomes frequently undergo changes as they move between hosts, leading to the emergence of diverse variants and subvariants worldwide. The global proliferation is largely driven by their enhanced ability to transmit. Notably, certain variants exhibit accelerated transmission rates and appear to evade vaccine protection, necessitating the close surveillance. Since its emergence in November 2021, Omicron has spawned numerous offshoots and subvariants which have subsequently spread worldwide. In July 2023, the World Health Organization classified the BA.2.86 subvariant, nicknamed Pyrola, as a variant warranting close monitoring due to its distinctive genetic makeup. The Omicron descendant has sparked significant interest amongst virologists because of its altered spike protein structure, which exhibits a high number of novel mutations. Analysis of phylogenetic code revealed 35 distinct mutations, which compared to currently circulating SARS-CoV-2 variants. The unique mutations of Pyrola variant included those of spike proteins I332V, R43K, V445H, etc. Virological studies confirmed an evolutionary jump of Pyrola variant with several unique genetic changes that was significant enough to make the variant different from original SARS-CoV. The immune response against earlier infections and vaccinations seemed defined by the novel variant, as the mutations altered the spike proteins configurations and the vaccine was ineffective against such variants. Despite its unique genetic composition, Pyrola variant has failed to dominate among the actively circulating viruses since its discovery in the United States in September 2023. A new JN One subvariant, possibly a BA.2.86 offshoot, emerged in the Luxembourg, which notably demonstrated mutated L455S spike protein. It helped the JN.1 subvariant to aggressively transmit than the parent BA.2.86. WHO classified JN variant as SARS-CoV-2. Studies confirm the extreme immune evasive abilities of JN.1 subvariant that potentially increase the transmission rate. The evolutionary track of novel SARS-CoV-2 is depicted by the constantly emerging several subvariants from the original Omicron BA.1.1.529 variant, from which confirmed by the emergence of the latest JN.1 subvariant from BA.2.86. along with SL455S spike protein mutation affecting all the regions of the subvariant. The occurrence and spread of JN.1 subvariant are correlated with the recent increase in COVID-19 cases globally, thereby confirming the rapid evolution of the JN.1 subvariant from the Omicron variant. Due to the unique spike protein mutations as demonstrated by the subvariant, the risk of JN.1 is a global increased COVID cases. The JN variant responsible in the less than 5% of the COVID-19 cases in the United States in 2023 November, finally reaching 85% by the third week of January 2024. The new variant has very high prevalence in the United States during 2024 March. The variant became dominantly recently in China as per the China CDC during 2024. The variant is also dominant in several countries worldwide, although the symptoms invariably remain the same as witnessed in infections by the original SARS-CoV-2 and subvariant infected other subvariant. CDC has observed that the JN.1 subvariant infectious cases were rising. Although this infectivity is apparently low, its transmissibility is increasingly high. HV1 and JN1 strains of subvariants are both distantly related to the original Omicron strain that emerged by 2021, and this could be diagnosed by using standard diagnostic kits. Data suggests that even the modified and more advanced vaccines may be ineffective against BA.2.86 subvariant, although a booster dose vaccination partially protected. Antiviral therapy was effective against them, even more effective than when administered earlier. Vaccines developed earlier using the original SARS-CoV-2 strain seemed ineffective against the subvariants. Newer booster Moderna, Pfizer, and Novavax versions designed against XBB.1.5 especially offered better protection than the earlier vaccines against the circulating Omicron lineage. The immunity from the vaccination reportedly lasted for over a short while would wane over time. The immunity almost completely waned in 6 months after the second booster dose, thus making a vaccinated individual susceptible to the currently circulating Omicron and its subvariants. A better protection after the third or second booster vaccination was reportedly seen. The second booster dose during a currently available monovalent messenger RNA and non-mRNA vaccines exhibit improved efficacy and simulated both the mediated immunity and Omicron, and is supporting the reason to develop new vaccines against a currently circulating viral subvariant. Booster dose effectively minimize the disease severity by JN.1 and HV1 subvariants. Pfizer's mRNA technology is known for its ability to rapidly adapt to new variants. Updated booster shoots that target specifically subvariants are being developed, and some studies suggest they may be effective against JN.1. The Pfizer JN.1 vaccine is designed to protect against the latest variants of the COVID-19 virus, which continue to evolve with the new strains emerging. The JN vaccine's other enhanced immunity, helping to stay a step closer to virus and better preparedness. Comirnaty is a highly purified, single-stranded, 5-capped messenger mRNA vaccine. Each dose contains COVID-19 mRNA vaccine embedded in lipid nanoparticles. It uses mRNA technology, which is a way of sending instructions to host cells in body for making copies of spike protein like the spikes you see in the sticking out of the coronavirus. Our cells recognize that this protein doesn't belong and the immune system reacts by activating immune cells and producing antibodies. This will prompt the body to recognize and attack the real SARS-CoV-2 spike protein if you become exposed to such viruses. Some studies have shown that Sputnik V can elicit robust antibody response and may also offer some protection against certain variants. However, it is worth noting that this protection might be lower than that of mRNA vaccines, especially against newer variants. So modern vaccines has been updated over time to target new virus variants. First introduced in December 2020, the original COVID mRNA vaccines from both Pfizer and Moderna protected against the original SARS-CoV-2 viruses. Thus have been replaced multiple times since then with the shots targeting different iterations of the Omicron strain of the virus. In 2022, bivalent vaccines targeted original viruses, Omicron variants, and in 2024-2025, a new updated study to protect against KP2, which circulated earlier in 2024. These vaccines are no longer in use now. The Novavax vaccine, brand name Nuvaxovid, was the fourth COVID vaccine to be administered in the United States after Johnson and Johnson, which is no longer available. The Novavax vaccine is only non-mRNA updated COVID vaccines available in the United States with 90% efficacy in clinical trials. It is similar to make some of the other vaccines and can be stored in refrigerator, making it easier to distribute. That's after the Center for Diseases Control and Prevention updated mask guidance for customers, emphasizing the N95 and similar high filtration respirators offer the best protection against the COVID-19. The N95 is more protective because it has a better face feel in general than a KN95 mask. Thanks for watching my broadcast. Please subscribe to my channel.